We'll now proceed with the introduction to the panel of the reactors. And to react on the talk of Dr. Carlos Mesquito, which is about the long and winding road to the acquisition of competencies in trauma surgery, is Dr. Hayaki Uchino, who is a trauma surgery fellow at McGill University Health Center, Montreal, Canada. He's a former attending in general surgery and critical care medicine in Kurashiki Central Hospital in Kurashiki, Okayama, Japan. A former trauma fellow, Department of Surgery, Ebendale Hospital, Peter Maritzburg, South Africa. A former trauma fellow, trauma unit, Kosi Albert Bethune Central Hospital, Durban, South Africa. And a former trauma and acute care surgery fellow at the Yogo Emergency and Medical Center, Kobe, Yogo, Japan. Colleagues, let us welcome Dr. Hayaki Uchino for the reaction. Doctor?
Hi. Thank you so much for the kind introduction. Hi, so my name is Hayaki Uchino, one of the trauma surgeons. Basically, I'm from Japan, but currently the trauma fellow at the McGill University Health Center in Montreal in Canada. So it is actually really a great honor to be invited as the reactor for this special webinar today. And I'm going to make a comment on the great lecture by Dr. Mesquito. So the title of the lecture, The Long and Winding Road to the Acquisition of the Competencies in Trauma Surgery, reminds me of the time, including now, about my training to become a trauma surgeon. So the trauma surgery training is always an issue for the young surgeons who wants to be a trauma surgeon. And especially for the surgeons in the country where the trauma volume is low and where there no specific trauma training program exists, like Japan, where I am from. And I think that one of the answers to this is the off-the-job training, as Dr. Mesquito was presenting in his lecture. I'm really impressed with the great work that Dr. Mesquito has achieved to implement so many courses to his country. And in Japan, we've also started the courses such as DSTC, ASSET, and ATOM courses. And I believe that these courses have a great impact on our trauma training in Japan. And also introducing DSTC to Japan, and the process of introducing this course gave me an opportunity to meet Dr. Chu. And that is why I'm here to be as a reactor. So thank you so much, Dr. Chu. But the thing is that you cannot become a trauma surgeon only by taking such courses. And what you need is an exposure, a lot of exposure to the real trauma cases, both not only like the blunt, but also the penetrating trauma. So talking a little bit about myself. So I completed my general surgery training in Japan. And I did my first trauma fellowship in South Africa. Then I went back to Japan. I worked as a staff there and trying to establish some sort of the trauma care system in one of the hospitals there. But eventually I realized that I still have to learn more about the trauma system and the logistics. So at the time I was thinking about this, actually the Professor Ken Beaufort, I'm sure everyone knows about him. He's a famous trauma surgeon in South Africa who gave a few talks before in this webinar as well. So he introduced me to Dr. Tarek Razik. He's the head of the trauma team here in Montreal. And also he is well known internationally, and he gave us a talk before in this webinar. So now I'm doing my second clinical fellowship here in Montreal. And I've been having great exposures to many cases. And to be honest, I've been learning a lot. So I realized that learning is never ending. even I'm like a 1920, like a PGY in 1920. But I think the most important thing I would like to emphasize here is the global and international relationship, both individually and organizationally. I could not have achieved my career without those encounters and the relationship with great surgeons and the great friends all over the world. And as Dr. Mesquito was saying in his lecture about the importance of the friendship and the team internationally. And I believe that this Asian collaboration of trauma will give those information or the opportunities for future trauma surgeons, not only in Asia, but also all over the world. So again, I just want to express my gratitude to the ACT committee for giving me this great opportunity, and hope everyone will have a wonderful holidays. Thank you.
Dr. To react on the social value of trauma systems given by Professor Russell Gruen, Dr. Herbosa is a professor of emergency medicine and trauma surgery at the University of the Philippines, Philippine General Hospital. He's a faculty of the National Telehealth Center at the University of the Philippines, Manila, and is special advisor on the National Task Force Against COVID-19 in the Philippines. He's the former executive vice president of the University of the Philippines System, chairman of the Physicians for Peace, Philippines, the former board member of the World Association for Disaster and Emergency Medicine, or the WADEM, the former professor of emergency medicine in University Kebangsaan, Malaysia, and the founding chairman of the ASEAN Collaboration for Trauma. Colleagues, let us welcome Dr. Tedora Herbosa for the reaction. Dr. Herbosa.
Thank you very much, Joseph, and thank you very much for that kind introduction. First of all, let me greet all our speakers for their tremendous talks. And I have been assigned to give a reaction to the talk of Professor Russell Gruen. And Professor Russell, I enjoyed your talk very much. That's a very personal talk because like you, I've been in the field of trauma for a long time. After training in general surgery, I traveled around the world trying to look for the trauma system that would fit the Philippines. And that has brought me to several countries like Israel, the US, in Australia as well, trying to look at the trauma systems there, in other countries like Japan. And true enough, as what you said, we've got to look at what is the big picture. I think the message you gave us is for the young surgeons here, the surgeons, the trauma surgeons that are moving up in the fields of trauma care and trauma systems, is to really remember, look at the system, look at the big picture. And you started your talk with something that immediately caught my attention. When you talked about that ad of the Victorian trauma system, talking about an image, the whole image actually, it's a strategic communications plan wherein it captured the people of Victoria and gave them a message. You're okay, you're at Alfred. And that to me is a very important message to many of our colleagues in the trauma field. I now chair what is called the Commission on Trauma of the Philippine College of Surgeons. It is our approach, and you see the logo behind me, it's a transdisciplinary approach to looking at the problems of trauma in my country. Before, we thought trauma was just the surgeons, but you actually elucidated it. That's why I really enjoyed your talk. And you started with about communications. And this is what we're trying to do now. We are trying to reach out to everybody in the government, in the other colleagues in the rehab sector, in the mental health field as well, to help us build a robust trauma system in my country. And that is why your talk really touched me. The trauma system as a well-being is also very interesting to me because after becoming a trauma surgeon and being head of an emergency department of the largest university teaching hospital, I became Undersecretary of Health of the country. And I not only took care of a trauma system, I took care of a whole health system. So what you were talking about really touches me right there in how it actually makes trauma surgeons learn how to lead and learn how to use what they've learned in building trauma systems to actually build a better well-being for everyone. I also understand Maslow's hierarchy of needs that you actually explained. And I think all of us, when I was young, I wanted to learn how to operate on trauma, the most complex trauma cases. When I was a little older, I wanted to make sure that patients got to the trauma surgeon and help develop pre-hospital systems in my country. After that, we developed a trauma fellowship program for a long time, the only trauma fellowship program in my country. But eventually, we had a second one, and now we're building a nationwide trauma program. It was slow, but it's going to get there the same way Victoria was able to decrease trauma deaths in the past 50 years. The trauma systems approach is really something we've taken on. At the Trauma Commission, we have 5 clusters. We have a injury prevention cluster. We have a pre-hospital and emergency care cluster. We have a hospital cluster headed by our president, Rolando de la Cruz, who heads that cluster, which is the hospital systems. And then we have a rehab cluster led by our armed forces of the Philippines. And you gave a mention on this in your talk, because I realized that we only took care of trauma patients and made them get out and be discharged from the hospital and worried about the next trauma patient. When in fact, there is something we need to worry about. It's not about saving them. It's about finding out if they're able to go back to work and become productive members of society. And this is what we're learning from our colleagues in the armed forces. They take care of their soldiers wounded in battle and make sure they get back as productive members of the armed forces. And now we have a program to actually pattern and approach rehab of trauma the same way our armed forces have approached wounded soldiers. And we'll apply those principles in the civilian setting. True enough, the lessons learned from Professor Gruen is really how young surgeons will look at the big picture. Trauma doesn't stand alone. And in the strong basis of this is you've got to have data. In the world where we are now, we're swimming in oceans of data. You need to organize them into rivers of information. And then from there, you'll be able to create lakes of knowledge. And from the lakes of knowledge, you get droplets of wisdom that Professor Gruen had given us in terms of its application to society. 50 years to decrease mortality, that's an amazing accomplishment. I wish I could do that in my country. I've been practicing for about 3 decades now, but we've gotten slowly. We're not as rich as Australia, probably. We have more difficulties in terms of answering the gaps of our health system, but we do learn from each other, and the international nature of all these meetings do help give us a bigger and better picture. So it's very important to have innovation, continue to sustain everything in terms of making sure that the public is aware of what we do as trauma surgeons. It's also very important to navigate them in terms of what he called a case manager. We call it a patient navigator. We need to have patient navigators for our trauma patients in this very, very complex system. And trauma care system is really a very complex system. And we've established a trauma registry in my hospital. And I just got a grant from the government last year while we were at COVID. Well, actually before we got COVID, to study 10 years of road injury in the Philippines. And we're coming out with our publication soon on the findings of those road injuries. And it's a nationwide study. And soon we're going to our rural areas to actually understand also and find out how to fix our trauma system. So very important is system governance. How do you rule that? The quality improvement of how you keep improving your trauma system. And of course, provider education. I would understand this webinar was a gold mine. It was a gold mine that happened because of COVID. They discovered that now we can have a meeting like this with several experts from Portugal, from Australia, from Africa, and we're all exchanging ideas, and we get to see a bigger picture of the trauma care. And lastly, I cannot really underemphasize the fact that as trauma surgeons, we need to follow up our trauma patients and make sure we look at that, what we call, what he described as the non-mortality measures or metrics. I like that. I think it's very important to look at the long-term effects of trauma on our patients and really understand the true burden of illness, especially for those that are disabled and have to change their whole lifestyle. So very important, look at the big picture. Thank you, Professor Gruen, for making us see this big picture for trauma and the well-being of our society. Merry Christmas and a Happy New Year to everyone. Thank you very much.
We would like to invite Dr. Daniel Lee from Singapore, who will be reacting to the talk, the third talk by Professor Wullsleger. He is a surgeon from Singapore who is currently working at the Khoo Teck Puat Hospital. He completed his fellowship in the FRCS from the Royal College of Surgeons, Edinburgh in the year 2015. Following that, he advanced his post-surgical fellowship that specializes in advanced colorectal cancer at the John Gallagher Colorectal Surgery Unit at St. James University Hospital in Leeds, UK. He also completed another post-training fellowship in trauma at Royal London Hospital. He had experience firsthand on managing mass casualty at the hospital during the London Bridge terrorist attack in 2017. He is now a consultant colorectal and trauma surgeon in Khoo Teck Puat Hospital to the north of Singapore, with particular interest in pelvic operations. And in the field of colorectal, he specialized in locally advanced rectal cancer that involve extended resections such as pelvic accentuation. With this expertise, it truly complements his trauma practice, especially in handling complex pelvic injury as well. And let's invite Dr. Daniel Lee to react to the third talk by Professor Martin Wullsleger. Dr. Daniel?
Thank you, Lynette, for the kind introduction. A very good morning, good afternoon, and good evening to everyone here. I'm Daniel. I'm a consultant surgeon working at Khoo Teck Puat Hospital in Singapore. Really glad to be here in this webinar, and I'm here to react on the talk by Dr. Wullsleger on the entering the new normal, its impact in the management of trauma. I think it's probably a coincidental arrangement that I'm actually reacting to this talk, as in I actually did my elective posting as a medical student in Royal Brisbane Women's Hospital. It's probably almost 20 years ago, and that pictures of the front of that hospital that Dr. Martin has put up truly brings back memories. I actually enjoyed my time there. I don't think we met though. So I think Singapore and Australia had almost a fairly similar experience in terms of COVID. I would say that both countries has actually achieved fairly successful control in the spread of the COVID. But despite that, this COVID does change the world, the way how we work now. Particularly, I think in the already stretched system, even before COVID time, all the hospitals are almost at stretch at various points of time. But now having to deal with a surge of this acutely ill respiratory symptoms coming of patients that come through our emergency department definitely brings put on a toll to our hospital system, particularly with regards to trauma care, because we know that trauma is actually very resource intensive and demanding. I actually like the picture, one of the pictures that was put up by Dr. Wullsleger on those people that attend to a particular very severe major trauma. I think before COVID, this is so-called a norm site that we see, where you just have a lot of people attending to one severely injured patient. But I think this COVID has changed us in terms of being number one. Most of the time that all the people that attended to these patients will probably need to don on PPE, and of course we also try to minimize contact, and also not so much of not being able to, not wanting to attend to the patient, but also during the time when there's a surge of these ill patients coming in, there's actually a shortage of manpower. A lot of junior staff sometimes also need to just left to attend to these major trauma patients without any supervision. And at least I could say this was our early experience when we first encountered this COVID period. I also believe that in countries where there's actually a high COVID pandemic, this equally affect a lot in terms of delivering the trauma care, particularly perhaps also unable to meet the mark of a golden hour. So there's definitely some form of delayed intervention in guidelines. Of course, the silver lining to this, so to call, during this pandemic is that there's actually a reduce in the trauma case. So and I think it's a global trend, and we experience that also in Singapore itself. So pre-pandemic, what we usually experience would be a lot of road traffic accidents, high-rise fall victims, and all those things. But during this pandemic time, there's actually a reduce in terms of even the major trauma cases, and which is similar to what Australia experienced as well. And the other thing that we notice in our local country, in Singapore, is there's also a change in the injury pattern. In fact, because of lockdown, we actually see more interpersonal violence and even geriatric trauma, having geriatric patients fall from home and all these things. So this trend and this data is actually important for us to actually prepare us to put our focus and priority correctly in terms of the trauma care in the future, should another lockdown be imposed again. But of course, we can't stay locked down forever. Countries and borders need to open, and that's why this talk is particularly important, whereby I'm very I learned a lot from Dr. Wullsleger in terms of how Brisbane Hospital has actually prepared themselves entering into the new normal. So if there's another treatment and this preparation, there's a forward planning that has been in place now. And as Dr. Wullsleger has pointed out in the presentations, this forward planning should not only confined to the local hospital, but it should also involve the other regional hospitals, and also at epidemiology or a public health level. And I think in terms of the hospital, there's always the need to ramp up intensive care resources. And I particularly like the idea of this having the ongoing trauma educations and simulations. Because this is very important, having a pandemic that comes by that change the protocol of how we attend patients. We really need this simulation exercise to go on to get everyone familiarized with the new protocol, and also the improvement of this peri-operative services, because some elective works have been postponed, and hence we can actually put emphasis onto the emergency work, particularly in trauma and acute care. And of course, there's also the utilization of the primary healthcare provider. And one of the things that Dr. Wullsleger mentioned was this COVID-ready initiative. I think recruiting our primary healthcare providers and having this such initiative would actually offload a surge of this COVID patient, because now we know that most of COVID patients have mild symptoms, and we can actually offload this surge of these patients presenting to us to the emergency department, hence having the able to allocate appropriate resources to the trauma care. And of course, I would like to add on that two other sectors will probably be important here. Would be the public health measure, whereby we can focus on primary prevention. I can speak from the Singapore experience, whereby we can see that there's actually a reduction in road traffic accidents during the lockdown period. Hence, that's important. Or this is the time that we can actually engage the local authority to talk about local traffic safety issues. And another important thing matters to address would be on the mental health, because of the COVID, there's a lot of tension and stress and anxiety among the populations, and one of the things that we should add on is to develop a remote assessment or care pathway to enlist patients at risk to prevent any interpersonal violence. So overall, it's great help for Dr. Wullsleger, and it gives us an insight into how to prepare should the next pandemic come down. In fact, we're not over with the pandemic yet. So that has greatly taught us a lot to how to prepare ourselves. Thank you. Wish you all a blessed Christmas and a happy New Year.
Who is going to be reacting on the talk by Professor Steve Moeng. Dr. Lee Kin Yan is the immediate past chairman of the Hong Kong Central Committee on Trauma Service, as well as the Vascular Surgery Subspecialty Group at the Hong Kong Hospital Authority. He is also the Honorary Clinical Associate Professor at the Lee Ka-shing Faculty of Medicine, University of Hong Kong. He is the current country representative for the Asian Collaboration for Trauma, and he is a former Traumatology and Vascular Surgery Fellow at the Harborview Medical Center, University of Washington, USA. Besides that, he's also the international instructor for the DSTC course and the faculty for the ATLS, ASTC, Stop the Bleed, HKE, AW, and STAR courses. So we'd like to invite Professor Lee Kin Yan to give his reaction to the talk by Professor Steve Moeng on doing trauma in the age of pandemic.
Hi, good evening, everyone. I'm Kin Yan Lee from Hong Kong. Professor Moeng, I enjoy your lecture very much. You know, precious and concise, and you have summarized all the recent trauma epidemiology during the COVID-19 pandemic. So much has been said by the other reactor. I think my reaction will be a short one. And actually, you know, in Hong Kong, we had SARS 17 years ago. We have experience. So we Hong Kong people quite vigilant, and our Hong Kong government or even the hospital is quite vigilant for this kind of a new COVID-19 pandemic. But things have been changed. In the past, we don't have the people chicken out, but now with the people always have sick leave or even on go on strike. Same in Hong Kong, trauma is quite similar to as Dr. Steve said. Number have decreased during the COVID-19 by around 10%, but the mortality is higher than before. Even my hospital is not doing very well as before. There's quite a few preventable deaths. It's a very sad thing. And in our hospital, we receive all the trauma patients, and we incorporate the COVID-19 prevention in our room. All the patients have the nasal swab test, the COVID-19 test, and the test is available in the 2.5 years. And then we deal with the trauma patient as usual. And for the patient have the intubation or need to be intubated, we will deal with the patient with full gear, like the facial mask and N95 mask. If the patient don't have the intubation, so we just have the simple mask as that. Thank you, Steve. I have summarized all this data during the lockdown period, and this is very concise. But as you said, during this period, there still affect the old people and then fragile people, and also there's some increase in hip fracture and even the mortality. I'm quite agree with you. We should incorporate the COVID test and all our trauma patients and stay vigilant. And the supply of PPE is very important. And we must allocate the manpower to the trauma rather than pay too much attention to the COVID-19 or even the new virus. And we must stay vigilant. Okay, thank you very much. Merry Christmas and New Year.